Hello, we are here at EHJ Today. I'm Udo Sektem from Stuttgart in Germany, and I have with me Professor Colin Berry from the University of Glasgow in Scotland, which is still part of Great Britain as we speak here. And finally, here's Dr. Bernard de Bruijn, who is famous for having invented FFR measurements, and he works at the Cardiovascular Center in Aalst in Belgium. We're going to discuss the famous NSTEMI study, a study that was the results of which were first shown here in Barcelona at the ESC Congress. And could you perhaps summarize for us the study?
Yes, thank you for that introduction. The famous NSTEMI study is focused on patients with acute coronary syndromes. These patients are the commonest indication for invasive management. They have an adverse early and longer term outcome. The management of these patients involves invasive angiography as the standard of care. Treatment decisions are made during the urgent care pathway. The cardiologist usually does not have information on stress testing, non-invasive tests that are usually available for cath patients who've got stable symptoms. So the management of NSTEMI patients is placed at a certain disadvantage. And this is troublesome because these patients have a higher risk. Furthermore, angiography is subjective in its interpretation. The visual assessment of a stenosis severity can vary between cardiologists, and therefore treatment decisions can be uncertain also. So with these uncertainties, there is a desire to increase objectivity about decision making. And Bernard de Bruijn and colleagues have really developed the evidence base for functional assessment of the coronary stenosis severity, one could say an invasive method of assessing lesion level ischemia in stable patients. And the evidence base is well established for the prognostic benefits of fractional flow reserve in patients with stable coronary disease, and there are no prospective randomized trials of FFR in patients with acute coronary syndromes. So that's the background for the rationale for undertaking the famous NSTEMI developmental clinical trial, in which we endeavoured to obtain as much information as possible about those uncertainties in the context of a multi-centre clinical trial.
So this was a multi-centre trial in Great Britain?
Yes.
Who participated?
There were 6 hospitals. By design, 3 of these hospitals were academic centres and 3 were not. Mm-hmm. We were interested in diversity in all aspects of the study. We did not want a study that was delivered by FFR adopters. We wished to implement a study that could be applicable to usual clinical practice globally, for that matter, albeit we did implement it in the United Kingdom.
Okay, so you had some centres who did not routinely use FFR before the study?
There are 2 thoughts that come to mind with that question. So first of all, when we looked at FFR in acute coronary syndromes, there are national audit data that we accessed before setting out in this study. So FFR was used in NSTEMI patients in 2.8% of procedures. So on the one hand, there are no experts with FFR in patients with acute coronary syndromes. But of course, FFR is used in stable patients, and it tends to be used more often in academic centres. And I would include our own hospital, the Golden Jubilee National Hospital in Glasgow, as proponents for FFR. And with all due respect to some of my colleagues in the other hospitals that we included, they perhaps are not recognised for being FFR adopters in the way that perhaps the Golden Jubilee Freeman Hospital in Southampton, which are the academic centres in our study.
So what were the main results of your study?
The design of our trial focused clearly on primary and secondary outcomes. Talking about the secondary outcomes first, we were interested in feasibility, safety. We were interested in disclosure of the FFR result, and would a cardiologist adopt that result into their treatment plan, or alternatively would they disregard it and continue with their initial treatment plan based on the clinical history and the angiogram. So those aspects were key parameters in our study. Other aspects were costs, hospital costs, procedure utilization. The primary outcome was the between group difference in medical therapy alone for those patients randomized to either FFR disclosure or to the control group in whom the FFR result was measured but was not made available to the clinicians. So we had rigor about control and blinding in order to make between group comparisons.
Okay, so what did you find out? What came out of it?
So the primary outcome was a reduction in revascularization between the FFR and angiography guided groups. In other words, medical therapy alone was used in 22.7% of patients in the FFR guided group, and in the angiography guided group, medical therapy alone was adopted in 13.2% of patients, and this difference was statistically significant. Furthermore, we followed up all participants. We achieved a 100% follow-up rate in the 350 patients, and this difference was maintained over time to 12 months. So there was no late catch-up in revascularizations over time.
Okay, so this is the well-known phenomenon that when you use FFR, you show in general that more stenoses that appear borderline significant are in fact not, rather than the opposite, that FFR shows that these stenoses are relevant and you reduce the number of interventions. Bernard, that is
yes,
a general observation.
I agree. It's a general statement which is correct, even though we have to realize that we underutilize the FFR in very mild stenosis, and in particular in the proximal AD, left main, a big right, dominant circumflex in the proximal part of these vessels. Mild stenosis might also be hemodynamically significant, but being mild, they don't trigger the use of fractional flow reserve, and therefore your statement is a little bit biased, is correct from the data, but we are all a little bit biased, still biased by the angiogram.
But where would you set the border? Should we do this in 20% kind of irregularities or 10%? Because the cutoff now is 30% where it is recommended by the guidelines.
Well, you're right that the cutoff is going down and down with new guidelines and new reviews and papers. Now, my, let's say, attitude is to be particularly prudent in big vessels which are prognostically very important, which supply a large myocardial mass, viable myocardial mass, and again, this is the proximal LAD, the left main and proximal dominant vessels, but especially the proximal LAD and the left main. These are lesions which sometimes are really surprising, and nowadays we have learned that we have to believe in these functional assessments, and we have to be prepared to stent even a 30% stenosis in an LAD, because very often they are associated with fractional flow reserve which are strikingly significant.
So what are the practical consequences from your study?
So we have demonstrated that FFR measurement is absolutely feasible in patients in whom the clinician believes that a pressure wire can be passed. Remarkably, in the 350 trial participants, FFR was measured in 100% of these subjects. There were 706 lesions, and FFR was measured in 704 of these lesions. the subtext to some of the uncertainties with FFR in ACS patients is around practicalities, using instrumenting a coronary artery with the pressure wire, or indeed the use of adenosine. These uncertainties, I think we can be greatly reassured from the results in this study that the pressure wire use in ACS patients in whom the cardiologist believes it could be used is absolutely feasible and it's safe.
But does it have any consequences? It takes time. You sometimes have to do it at 3 o'clock in the morning. What do we get from it in the long term for the patient?
So that's a great question, because individual doctors need to interpret and apply the results of clinical trials in an individualized manner. So clearly this study was performed under ordered circumstances, and sometimes clinical practice isn't as ordered as we would like it. So I certainly would caution the application of the trial results in clinical practice in a pragmatic and sensible way.
Yeah, well, along the same lines, I think it is true that we have to be prudent for the time being in applying the results of the FAMOUS-NSTEMI to the non-STEMIs. It would be a bridge too far, I think, today to expand these results to STEMIs and all kinds of acute coronary syndromes, even though we all would like to see it happens, but we have to be prudent for the moment. You agree with that?
So if I could just pick up on that. FAMOUS-NSTEMI was a developmental study. It was not a practice-changing study. For change in practice and indeed change in guidelines, we need evidence that's impactful on health outcomes and cost effectiveness. Our trial was designed to gather that information, but it was not powered to inform interpretations. What we have shown is that when FFR is disclosed, the result is made available to the operator, it is impactful on treatment decisions. We also did not detect any difference in health outcomes in terms of a negative effect or indeed a positive effect. Coming back, of course, to the point that we are not powered to make any robust interpretations, and for me, one of the main conclusions from the FAMOUS-NSTEMI trial is that we do indeed need a larger trial to answer that question.
Well, I think that brings us to the end of this interview. I thank you very much for your interesting data, Bernard, for your comments. Thank you.